All right, welcome. Today, we are diving headfirst into the fascinating world of neuroradiology. We're going to learn how to decode the different types of brain hemorrhages you might see on a scan to really understand the story that image is telling.
You hear the term brain bleed all the time, right? But the reality is so much more specific. A bleed isn't just a bleed. Where it is, what shape it takes, and even how old it is tells a completely unique and often incredibly urgent story. So how do we learn to actually read that story?
So here's our game plan. We'll start with the two heavyweights, epidural versus subdural bleeds. Then we'll play detective and figure out how to tell the age of the blood. After that, we'll explore some other traumatic injuries, talk about bleeds that aren't caused by trauma, and wrap it all up with a really specific and pretty dangerous complication.
Okay, let's get right to it. The two most classic traumatic brain bleeds. Seriously, understanding the typical patient story for each one is half the battle when you're trying to figure out what you're looking at on the scan.
Now, what's so cool here are these classic histories. For a subdural, picture an elderly person who has a pretty minor fall. The bleed is slow, sort of sneaky, and the symptoms, like confusion, might not even pop up for days. On the flip side, an epidural is pure drama. Think high-impact trauma, a skull fracture, the onset is sudden and severe.
And this is the key visual difference on the scan itself. A subdural hemorrhage looks like a crescent, and it can spread out across the brain because it doesn't care about the skull's suture lines. An epidural, though, is contained by those sutures. It can't cross them, so it's forced into this tight, lens-like shape. That one little detail, whether it crosses suture lines, is a massive clue. So you might be asking, why do they look so different? Well, it all comes down to the source of the bleeding. A subdural is usually from torn veins, where the pressure is low, so it's a slow ooze. An epidural, however, is typically from a torn artery. Arterial pressure is way higher, which means it can expand incredibly fast, build up a ton of pressure, and become a life-threatening emergency in a flash.
Okay, so now we can identify the type of bleed. The next big question is, when did it happen? The way blood looks on a scan changes over time, and learning to read that timeline is just a fundamental skill you have to have.
And I'm not exaggerating here. This is absolutely critical. As one of our sources puts it, this is maybe the most high-yield topic in all of neuro. So yeah, understanding how to age blood on a scan, you gotta know this stuff.
On a CT scan, it's all about density, how bright or dark it is. In the first hour, brand new blood can actually look dark. Then, for the next few days, it becomes bright white. That's the classic look you think of. The really tricky phase is the subacute one. It becomes isodense, meaning it's the same shade of gray as the brain tissue, which makes it dangerously easy to miss. And finally, after a few weeks, old chronic blood becomes dark again.
Now, if you thought CT was something, MRI is a whole other beast. You might have heard about these mnemonics to remember the signal changes. You know, the ones that kind of sound like baby noises? Yeah, let's just skip all that. There are much more intuitive ways to get a feel for this.
On an MRI, we're looking at T1 and T2 signals. In the acute phase, blood is dark on T2. But the game changer happens after about 3 days, when it hits the early subacute phase. It becomes bright on T1. That T1 brightness is the classic telltale sign of subacute blood. As it gets even older, it becomes bright on T2 as well. And eventually, you'll see a dark rim form. It's this whole evolutionary process that helps you precisely date an injury.
But head trauma isn't just epidural and subdural bleeds. There's more to the story. Let's widen our lens a bit and look at some other important injury patterns that can happen.
Now this one is a classic mimic. In a real subarachnoid hemorrhage, you see bright, dense blood filling up the spaces of the brain. But in a pseudo-SAH, what's really happening is that the brain itself is swelling and getting darker. This makes the normal fluid spaces look brighter in comparison, but it's not actually blood. It's a really critical distinction to make.
Next up, contusions. These are basically bruises on the brain itself. It happens when the brain smacks against the rough, bony interior of the skull during an impact. You see them a lot in the frontal and temporal lobes. And you'll hear two key terms. Coup is the injury right at the point of impact, and contre-coup is the rebound injury on the complete opposite side of the brain.
Now we're going to talk about what might be the most insidious injury of them all. It's one of the most severe, but it has this terrifying little feature. The first scan can look completely fine.
We are talking about diffuse axonal injury, or DAI. This isn't one big bleed, it's a widespread shearing of the brain's tiny nerve fibers from rotational forces. And because the damage is microscopic, the initial CT is often totally normal. The real diagnosis is made with an MRI, which can show tiny bright spots on T2 images, classically at the junction between the gray and white matter and in the corpus callosum. So, up to now, we've been focused on injuries from an outside force, but sometimes the bleed starts from within the body, due to an underlying medical condition. Let's look at how we piece together those clues.
In these cases, the patient's history is everything. If you have a patient with years of high blood pressure, you'd suspect a hypertensive bleed, which loves to happen in deep spots like the basal ganglia. But if you have an older patient and you see multiple bleeds of different ages scattered all around the brain lobes, you should really be thinking about amyloid angiopathy. The pattern tells the story.
And hey, it's always important to remember the less common causes, things like dural arteriovenous fistulas, which are basically just abnormal connections between arteries and veins. They can also cause subdural or subarachnoid bleeds, even without any trauma.
For our final topic, we're going to look at a dangerous complication that can show up after a bleed has already been treated. This is a situation where air itself becomes the enemy.
This is called tension pneumocephalus. So imagine a surgeon drains a subdural hematoma. Air can get into that new empty space, and if it gets trapped, like a one-way valve effect, it can't get out, and it starts to build up pressure on the brain. It's a lot like a tension pneumothorax in the chest, but it's happening inside the skull.
And this pressure creates an absolutely classic image. The trapped air gathers at the front and squeezes the two frontal lobes, separating their tips. The shape it makes on a CT scan looks, and I'm not kidding, just like the peak of Mount Fuji in Japan. It's a striking, unforgettable sign of a true neurosurgical emergency.
So, from the crescent shape of a subdural to the ominous peak of Mount Fuji, every single scan tells a story. It's a whole narrative written in shades of gray, and learning to read it, well, it can make all the difference. The only question is, what story will we decode next? Thanks for tuning in.